We go on to our next speaker, Dr. Sandhya Nair, who's a Senior Consultant Cataract Services from the Giridhar Eye Institute, Kochi. And she has another amazing video to show us. On to you, Dr. Sandhya.
Yeah. Yes, madam. Thank you, madam, for this opportunity. This is a case of traumatic cataract with 3 to 5 clock hours of subluxation. There was no vitreous in the anterior chamber. A dispersive OVD was used to seal the area of subluxation, and capsulorhexis was initiated in the area of intact zonules. Now, in these situations, a microrhexis forceps will give better control over the rhexis. Leaving a rim of at least 2 millimeter will facilitate the placement of capsule hooks or CTR if need arises. Dispersive OVD was injected inside again to maintain the anterior chamber depth. Now, the clear corneal incision was made in the area of intact zonules. Now, a good hydrodissection is crucial to facilitate nucleus removal and cortex removal. Now, 2 capsule hooks are placed in the area of dialysis to give anteroposterior support to the capsular bag. And these paracenteses are made vertical and close to the limbus. You need not tighten the capsule hooks too much. Now the capsule hooks are placed. Now rotation of the nucleus should be avoided as far as possible. Now a small trench was made using adequate power to avoid stress on the zonules. Now the nucleus was further chopped into multiple small pieces. The rotation should be kept at a minimum level. And then these pieces as emulsified using low phaco parameters, that is low bottle height, flow rate, and vacuum. This is needed for maintaining the anterior chamber stability to avoid chamber fluctuations and shallowing. Now, before pulling the phaco probe, you need to fill the chamber with OVD to prevent sudden AC collapse. Now, the nuclear pieces are slowly being emulsified. Now, after emulsification of the nucleus, now again OVD is injected inside before taking out the phaco probe. The cortex is removed by pulling it tangentially rather than radially. Now, after cortex removal, bag is filled with OVD and a CTR is placed. The tip is guided under the capsular bag using a Sinskey hook, and it should be placed in such a way that the tip is directed towards the area of weakness so that further extension of dialysis is prevented. Now, the eyelet is released into the bag using a Sinskey hook. CTR gives equatorial support to the capsular bag. It also helps in centering the intraocular lens. Now, the capsule hooks are released. A 3-piece foldable intraocular lens is placed inside the bag. You should avoid violent rotation of the intraocular lens. Okay, the trailing haptic is placed against the area of dialysis so that this also gives support to the bag in that area. Now the side ports are hydrated to prevent AC shallowing and the forward movement of the lens. Now pilocarpine is injected to constrict the pupil, and OVD was removed from above and behind the lens. Now intracameral moxifloxacin is injected and the side ports are hydrated. Thank you.
Thank you very much, Dr. Sandhya. It was not just a very good surgery shown, but you said exactly all the right things which need to be said when you're doing a surgery on a subluxated cataract, and the shallowing, not to have a shallow AC, and every step of the way, a perfectly done surgery. I would say that the only reason where in this 4 to 5 clock hour dialysis, you can get away with a CTR is because it was a traumatic cataract. But otherwise, if it is any other progressive zonulopathy, I think a CTS is indicated. Right, Dr. Minu? Dr.
Yeah,
Minu?
progressive means I think we should have a 2 CTS at least to fix up both areas. But this just because it is a traumatic one. And I was also about to tell that this is like listening to a textbook description of how to do subluxated cataract. But I would like to differ in 2 or 3 areas as far as my personal thing is concerned. first I would not change the location of my incision
Exactly.
according to the
Yes.
area of Zyle, because my comfort level is most important, because this is one of the most difficult cases I would do in fake. So my comfort level is very important, so I would not
Right.
change. And pre-operatively, all the subluxated cases, I have started giving mannitol now, so that this keeping on vitreous, keeping on coming usually does not happen if you shrink the vitreous a little bit. And one point which was said was avoid nucleus rotation. So I would definitely an easily rotating lens is more easily emulsified, but then trying to violently rotate and without a good hydrodissection and damaging more zonules is not a great idea. But if it's a good hydrodissection, I will definitely make tongue movements like this, left and right a little bit, so that it starts moves. Initial rotation movement is more difficult to initiate. So small movements to either direction makes it mobile, and then after this bimanually. And then keeping the aspiration flow rate least is my main point during phaco. Aspiration flow rate being more will pull the visco which you have kept there to plug the rexus area, and even the fluid which tends to go into the area of zonal dialysis and makes the vitreous hydrated, and it will finally, when you're aspirating cortex, we'll see that the PC gets bulged up and convex like this, just because 2 or 3 drops of BSS may go into the anterior vitreous and will bulge up the bag, and the bag will not open up for the later procedures. But a 3-piece lens in the bag is fine. Or the other option is to have a 3-piece lens in the sulcus and do a capture, which will help in some other ways also.
Yeah.
The rexus has to be small enough and centered.
Yes, I also am not for the incision, and I also felt the capsule hooks need not have been placed so close to each other. Could have been kept a little more distant from each other. Although since it was a focal dialysis, just 2 capsule hooks were sufficient for you.
Madam, if you have a dialysis like this, it's always better to bunch the hooks towards the maximum area of in the center of the dialysis. Now, if you have placed 2 hooks towards the edges of the dialysis, you still have an area in between which is likely to flop. And although it is definitely a great idea to give mannitol, just because you have given mannitol does not mean that you can't. I think.
And besides, all our patients nowadays, longevity is more, and we have many high risk. I'm surprised if you have your anesthetist in the theaters, we realize how many of your patients are high risk and how many need us definitely physician consult before you take them for surgery. So mannitol should not be used as a routine because subluxations we do see more often than we expect. So I am not for giving mannitol because of the health issues. These have to be factored in.
We get witness. We get witness for everyone. There is no, as we think, no. Generally, there is a concept that cardiac should not give mannitol. That's all wrong concepts. There is no, just like that cardiacs not getting mannitol is not, there are definite contraindications for mannitol in definite cardiac situations. And so many people who have had stents and all those things, they are not patients whom
is not a contraindication at all.
Not
so only the failures.
Failures
and overload. Yeah, such patients are not
low ejection fraction. Those are the patients we have to.
And low ejection fraction and coming with subluxation, that combinations are not so very common. Then we should avoid. Definitely, we should avoid in that cases. But then we
can generally say that traumatic ones are more in younger people and who don't have any contraindication for mannitol.
But we get fitness. Definitely, madam, agree. We get fitness and then only do.
Actually, in this case, the pupil was round at the end and there was no peaking. Actually, it's a good idea to put triamcinolone at the end to see whether there is any vitreous is there or not.
Yes.
Because I didn't put because the pupil was round and there was no peaking. And also, I just want to have to know the opinion of the panelist. If there's a generalized zonulopathy like pseudo exfoliation, so what I usually do is I place the lens, 3-piece lens in the sulcus and do an optic capture and place a CTR inside the back, then do an optic capture.
Yeah.
So I want to know the opinion of panelists also on this.
Yeah, that definitely is definitely the right way to go. But in a severe zonular weakness, which was there, then you have, if you still want to conserve the bag, then you have to use 2 CTS. You need to attach it to the scleral wall. Optic capture, as you say, does bail you out from average zonulopathies.
Just to add on to the point Minu made about some fluid going under the capsule,
Yeah.
quite often I have seen some small Rens fragments also.
Yeah.
You
Yes,
do
yes.
this, you do this, you think you have done a great surgery, and
Yeah.
at the end of it, you find that anterior vitreous has a lot of these
Powdery.
small fragments. Obviously, they have gone in through the zonules with your
Yeah.
osil
Yeah,
fragmenting.
even in regular
bouquet.
cases, in regular cases, not John. Dr. Malukin got a grand prize for his video for documenting this with an anterior segment intraoperative anterior segment OCT video. He got a grand prize for this.
So I think osil has sort of making the nuclei
And regarding
Maybe.
subluxations, I would suggest that before anything, you use triamcinolone as the first step. So
Yeah.
if there is any occult vitreous prolapse, that will be overt and you will be on your guard. So
Yeah.
first step of any subluxation, whether you see it or not, use triamcinolone at the beginning and wash it off, and then you can proceed with plugging and whatever.
It doesn't mean that the vitreous will not come in later. I mean,
Absolutely, yeah.
to keep a
Anytime it
watch.
can come.
Anyway, Sandhya, hats off to you. A very academic presentation.
Thank you, madam.